Good morning, everyone. My name is Havva, and I'm going to be taking you through a presentation on wrist fractures today. So we're going to go through very briefly the anatomy of the wrist and then hone in on distal radius fractures, looking at their clinical features, examination features, investigations and management. And then we'll briefly go through the complications as well as having a look at scaphoid fractures at the end. So starting with the anatomy of the wrist joint, it is made up of the carpal bones and the radius, and your proximal row here is made up of your scaphoid, lunate, triquetrium and pisiform bones. The distal row is made up of your trapezium, trapezoid, capitate and hamate. And they of course articulate with the radius, and it is the carpal bones forming a convex surface that articulates with the concave surface of the radius that forms your wrist joint. Having a look at distal radial fractures, they account for 17.5% roughly of all fractures in adults. They have a bimodal distribution, so you see a lot of numbers in younger patients and then the very older patients as well. In younger patients, it's generally due to high mechanism injuries, whereas in your older patients, it's due to low mechanism injuries. There is a skew towards more of these presentations in females rather than males, and the mechanism is a falling onto an outstretched hand. The risk factors, or the greatest risk factor for distal radial fractures, is osteoporosis. They can be classified, or there are 5 main types of these types of fractures. So we're going to look at Coles, Smith, Barden, Schofer's and die punch fractures specifically. Bottom line. A die punch is a depressed fracture of the lunate fossa of the articular surface of the distal radius. It was really hard to see on x-ray. That is a CT of it. I'm pretty sure it's this punched out area here, hence the name die punch. Of course, like all other fractures, these fractures can be further classified. So I've included the further classifications of the Coles and Smith's fractures. This was the type 4 fracture that is also a Schofer's fracture, a certain type of Schofer's fracture as well. So you can read them in your own time if you're interested. So typically your clinical features of this type of wrist fracture is pain, tenderness, soft tissue swelling, reduced range of motion in all planes, and wrist deformities, which is sometimes evident based on the type of fracture. So on the right there is actually a Coles fracture. You can see it's got the hump. That's typically characteristic of a Coles fracture. In a Smith's fracture, it is described as a spade, so it kind of flips the other way. Your examination is really important. It should include an assessment of the neurovascular status. So again, you're looking at your 5 Ps: pain, pallor, pulse, paresthesia, and paralysis. You should assess for motor and sensory function of the median, ulnar, and radial nerve. And particular attention should be paid to the sensation in the thumb and index finger, because acute median nerve compression is often involved, not normal. Sorry about that typo. Of course, assessment of your pulse and checking capillary refill on the fingernails and assessing range of movement in the wrist in all planes. Moving on to investigations and management. Your main investigations is going to be imaging. So typically you always start with your x-ray in 3 views, so AP, lateral and oblique. CT is indicated for surgical planning if you believe that this is going to need surgery, and evaluating the intra-articular involvement of the fracture. MRI is not typically used, but it is indicated to evaluate soft tissue injuries. Your management can be operative or non-operative. Your non-operative methods are closed reduction and splint or cast immobilization, and that requires adequate analgesia because the patient is awake. With the immobilization, it's really important to avoid positions of extreme flexion or extension. Your operative methods are ORIF, or open reduction internal fixation, closed reduction percutaneous pinning, or external fixation. And looking at the complications, these are some of your main complications, with your median nerve neuropathy being the most frequent. That's why it's super important to test the sensation of your thumb and index finger when doing a neurovascular examination. You can also have an ulnar nerve neuropathy if there is involvement of the ulna in the fracture. Radiocarpal arthrosis, which is typically seen in the younger population. Compartment syndrome, which we went into great detail in with our first week of presentations. And of course, like any fracture, non-union or malunion. And then I included a little bit on scaphoid fractures because although they aren't part of the category, they're still part of the wrist, and the carpals articulate with the radius, so it's important to be mindful of these fractures when considering wrist fractures as well. Particularly because the mechanism of scaphoid fractures is the same as the fractures of the distal radius, so falling onto an outstretched hand. So it's really important that you do check for a scaphoid fracture as well, because if it's missed, it can have some serious complications. So the scaphoid fractures are the most common carpal bone fracture, and it makes up 15% of acute wrist injuries. And the history is again falling onto an outstretched hand. You typically see pain in the snuff box, although not always. And the greatest complication there is avascular necrosis. And there are just some images of a scaphoid fracture there with a schematic as well, if you're like me and can't see them all the time. Okay, that's everything. Thanks, guys.